Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Fardon. I'm the chair and organizer of Grand Rounds. Thanks very much for coming along today. This is the final Grand Rounds of this semester. Normally, we'd have taken our summer break in July, but we shunted everything along because of COVID. Because everything's been moved or altered in some way by COVID, hasn't it? So this is we're going out with a bang, out in style, with Jonathan O'Riordan, who's one of our consultant neurologists and clinical lead for neurology here in Ninewells, and he has a clinical interest in multiple sclerosis. But he's going to speak to us today about something which I associate very much with MS, but I'm about to learn is not always MS, and that's the management of atypical optic neuritis, for namely neuromyelitis optica. The how and the why. So usual etiquette applies. Please mute your microphone if it's not muted already. If you have any questions, please put them through the chat to me or to the group, and we'll go through the questions at the end. And Jonathan, thanks very much for giving this presentation today.
So thanks very much for inviting me. As Tom said, this talk will focus on an unusual condition called neuromyelitis optica, in which optic neuritis is one of the presenting complaints. So many years ago, over 20 years ago, I worked in a place called the National Hospital for Neurology and Neurosurgery in Queen's Square, and also St. Thomas's Hospital in London. And every week for about 5 years, I made my way up to City Road to Moorfields Eye Hospital to do a neuro-ophthalmology clinic. Had an interest in optic neuritis. So optic neuritis is inflammation of the optic nerve, and generally it is a mild condition. There's modest visual loss, maybe pain and eye movement, and we generally do nothing with it. It has consequences in about 40% of patients who present with MS or multiple sclerosis. Their initial presentation is with an optic neuritis. Occasionally we give steroids. Sometimes it happens on its own, sometimes it happens in established MS. And in Tayside, about 2 patients would experience optic neuritis every week. Occasionally, however, I saw a number of patients in whom the initial presentation was like optic neuritis, but in whom the outcome was terrible. So these patients had unilateral or bilateral visual loss, and often they went blind. And occasionally they had weakness in their legs, such that became paraparetic. So without treatment, these patients were blind and paraparetic. I have 2 cases who we've seen in our service here over the last few years, just representative cases. We've set up a clinic for neuromyelitis optica in Tayside, and we probably have about 15 patients. But these are representative cases. So the first one, a 19-year-old male in 2014, presented with visual loss affecting the right eye. And there was pain and eye movement. So if you have an optic neuritis, you get pain and eye movement, very typical thing. Subacute and progressed over about 4 days. But over those 4 days, his vision went from being normal to counting fingers. He had some minor sensory symptoms in the left hand. So this was thought to be an optic neuritis, and he was given steroids. And we tend to give very high dose steroids, and he got 500 milligrams of methylprednisolone orally for 5 days. And that was it. He didn't get any steroid tail or any other immunomodulatory therapy at that stage. Well, things weren't quite right, and 4 weeks later, his vision in that eye was down to nil perception of light, so he couldn't see anything. And at that time, he underwent a series of tests. He had MRI, bloods, and a spinal fluid analysis. So these are his scans, and these scans here, these are FLAIR sequences, so fluid attenuated inversion recovery sequences. So they're T2 weighted sequences, but CSF is black. So that's an unusual thing. Not the best sequence for looking at the eyes, but these coronal sequences, this is the optic nerve here on his right side, that's on his left, and clearly there's a high signal in the optic nerve, and it went back quite a long way. That's a typical thing you see in an optic neuritis. He had a non-specific finding in the brain, a bit unclear what that represented, and nothing in the spinal cord. And he had a test called an Aquaporin-4 antibody, and I'll come back to that later. So in 2014, this was probably an experimental test, and it took about 6 or 9 months for the result to come back. And it went off to Oxford, and sometimes we saw the result and sometimes we didn't. As it happened, it was negative. He had matched oligoclonal bands in the serum and CSF, and because of the severe visual loss, he underwent tests for paraneoplastic disorders, so his CT of chest, abdomen, pelvis, and a mitochondrial test for Leber's, which was negative. 2 years later, however, he developed a left optic neuritis. So the right eye, he was blind, and the left eye vision went down to 6/36. So we gave him high-dose steroids and followed that with long-term steroids. And we also gave him plasma exchange, and he was commenced on immunosuppressant therapy. He had a blip about 6 months later and was commenced on rituximab. So that's 2016-17. And he stays on rituximab, and he's still on rituximab. And last year, around December time, I repeated the Aquaporin-4, and this was positive. So his diagnosis is neuromyelitis optica spectrum disorder, become Americanized, used to be called Devic's neuromyelitis optica. Unfortunately, vision in his right eye is nil perception of light, and on the left, he's left with residual visual vision of 6/24, so relatively poor vision. That's one case. Second case is a lady who's 45. She's a policewoman, and she was working with ladies of the night from Eastern Europe. And they had among their persona a mycobacterium. And she developed pleuritic chest pain and presented to David Connell with pleuritic chest pain, nocturnal sweats, and she had apical consolidation. So she presented with TB. She underwent bronchoalveolar lavage, and a mycobacterium tuberculosis was identified. She was commenced on anti-TB treatment, quadruple therapy. 8 weeks later, however, she developed distal paresthesia and visual loss. Again, there was pain in eye movement. And when she presented, vision went down to 6/12, so modest visual loss. Her tests at the time, bloods were unremarkable, B12, folate were normal. Plasma viscosity was mildly elevated, 1.82. And she had a connective tissue screen. So her ANA was positive, double-stranded DNA was also positive. Complement was normal. CSF was unremarkable. And she had this scan. So this one here is a stir sequence. It's kind of similar to the previous one, but in this, we're suppressing fat. It's a coronal sequence, and that's a high signal in the optic nerve. She also had this in her spinal cord. So this is her thoracic spine. It's probably over 2 segments, and she's got a high signal change in her spinal cord. So this lady, in the context of active TB, developed visual loss, and the visual loss was compatible with an optic neuritis, but she also had sensory loss. And the differential in terms of visual loss could have been a drug reaction. Could it be ethambutol-related optic neuropathy, which does happen? Could she have active CNS tuberculosis? She clearly has got abnormal autoantibodies. So does she have a systemic inflammatory disorder such as lupus? Or has she got an alternative diagnosis, which is a primary neuroinflammatory problem? So in terms of the ethambutol, it's dose dependent, and she did not exceed the recommended dosage. Visual loss with ethambutol tends to be fairly modest. Clouding of vision, reduced color vision, usually happens a bit later than the 8 weeks. If you give them high dose ethambutol, maybe 1 or 2%, probably not the cause of this lady's visual loss, but the ethambutol was stopped. Isoniazid could also cause visual loss, but probably not. So she started off at 6/12, and then over the course of a weekend, vision went down to nil perception of light. And this was kind of frightening for me because I remembered from previous life seeing a number of patients who had neuromyelitis optica and active tuberculosis, and they became blind. So she couldn't see anything with her bad eye, and she had weakness in the pyramidal distribution. So 2019, Aquaporin-4 comes back very quickly. So this was positive. So her diagnosis was, I call it DEVICS because that's the old name, DEVICS neuromyelitis optica spectrum disorder. And she also had lupus and pulmonary TB. So in terms of her tuberculosis, this obviously carried on. Her anti-TB treatment with Refiter, ethambutol was stopped. And we gave her high-dose methylprednisolone. So we gave her 1,000 milligrams of methylprednisolone despite the active TB. And we gave that over 3 days and followed that with oral prednisolone, 60 milligrams a day. We also gave her plasma exchange. And when we reduced the prednisolone, her vision got worse. And there was an interaction between our steroids and Refiter. So I had thought she was getting perhaps 40 on my reducing dosage, but it was relatively less. We started rituximab. So in the context of active TB, we started rituximab to prevent her from going blind and paraparetic. And she carried on her anti-TB treatment, and she carried on her rituximab. And TB seemed to be sorted out. And now visual acuity 6/6, maybe slight reduction in color vision. She's no persisting lower limb symptoms and no active TB. So what is DEVICS neuromyelitis optica? So this chap is Eugene Devic, and he was a physician stroke neurologist in l'Hôpital de la Croix-Rouge, which was a hospital in Lyon. So this is Place de la Croix-Rouge, and the hospital was there, but it's no longer there. And he had a 21-year-old female who developed neuromyelitis optica. And he wrote this up, and he encouraged one of his registrars, we call him a registrar at the time, Fernand Galt, and Fernand did a thesis on this. So Devic published it in one of the French journals, and Fernand Galt did a thesis on neuromyelitis optica. And then in 1914, a chap called Golden referred to the condition as DEVICS neuromyelitis optica. Didn't realize that an ophthalmologist called Albert had described the ophthalmological findings and spinal cord disease in the Lancet about 20 odd years earlier. So it became known as DEVICS neuromyelitis optica. And over the years, there were a number of reports on this condition, sometimes familial, and it was always labeled as a variant of multiple sclerosis. An abnormal variant, a severe variant, but a variant nevertheless. And it was kind of treated as that. There were some pathological reports. And it was part of my thesis looking into the clinical CSF and MRI findings in DEVICS neuromyelitis optica. Quite a while ago. I should have removed 1996, but I didn't. So when I looked at these patients in the past, it was clearly more common in females. The age of onset is variable, but sometimes they're young, sometimes they're older. Median age was in the 30s. Tends to be multiphasic. So multiphasic means comes and goes. Sometimes monophasic, and laterally the monophasic ones are probably related to an anti-MOG antibody as opposed to Aquaporin-4 antibody. And it's not very common. And a lot of the patients we had had autoantibodies, like Our Lady, and a number of them had TB. So in terms of the visual outcome, tended to be bilateral in most patients. And the outcome without treatment was very poor. So this is probably natural history. And in the 90s, we didn't have any treatment for MS, so we didn't have any treatment for neuromyelitis optica. And counting fingers or worse in one or both eyes of 85% is more or less blind. Paraparesis, so 2/3 of them were paraparetic. So the consequences of missing this are blindness and paraparesis. And when you look at the imaging, so this is a sagittal T2 weighted MRI scan, and this is an axial scan. And what you'll find here, so this is the chin, back of the neck, vertebral bodies, and this is the spinal cord. And this whole spinal cord is abnormal. So this is an artifact. This here should all be a little bit darker on this sequence. And you've got this whiteness. So from here, the whole way down. And that's a typical bad devic type myelitis. When you look at it on the axial sequence, the whole of the spinal cord is affected. So this is what we saw. This is a typical imaging characteristics on this, and when it happens, it's not good. Pathologically, you get, well, this obviously is a patient who passed away. So that means that the neurological problem was clearly severe. And you can imagine in my previous case there, the cervical spine was affected, the sort of almost up to the medulla. So they will have had respiratory compromise. And so patients do die. And so this particular patient had a lot of macrophages within the lesion. And there was a sharp demarcation between the white matter and the plaque. And there were lots of cells, so lots of lymphocytes around, so the blood vessels, and lots of lymphocytes around the blood vessels. So a very inflammatory process. But there was also a reduction in axons. So that's a very inflammatory and destructive process. And there was also reduction in oligodendrocytes. So a axonal loss, oligodendrocyte loss. Might have oligodendrocyte loss in MS, but in the acute ones, you tend not to have as much axonal loss. So this is a very inflammatory, a very aggressive inflammatory, and a very degenerative process. So then, in the Mayo Clinic, in the early noughties, they were looking at paraneoplastic antibodies. And so what you've got here is a brain substrate, and GL, you remember from your neuroanatomy days, so a granular layer, molecular layer, so that's cerebellum, smooth muscle here, SM, and midbrain. And so they had a number of sera, and they found this. This was not something they were looking for. And it appeared that this was staining blood vessels. And along the Virchow-Robin spaces, there seemed to be something. So something was present in the brain, something was present in the subpia of the midbrain, along the blood vessels, and they didn't know what this was. So they were looking at paraneoplastics, so anti-neuronal antibodies, anti-Purkinje cell antibodies, and they found this. And when they did dual immunofluorescence, it confirmed that this thing was binding to the adluminal surface of cerebral blood vessels. So something binding blood vessels in the brain. And then they looked at where all this sera had come from. And some of these patients had neuromyelitis optica, and some had a condition which looked like neuromyelitis optica. High risk condition would be my first patient who had bilateral visual loss. Some had MS, some had opticospinal MS. So that may be patients who had neuromyelitis optica who were diagnosed as MS, and some had miscellaneous. So these are the antibodies. So when they looked at it, most of the antibodies came from the neuromyelitis optica patients, some from the high-risk patients. Typical MS didn't have them, classical MS didn't have them, and the SLEs didn't have them. So what was it? Well, as it turns out, this was an antibody against a channel, an astrocyte water channel called Aquaporin-4. So Aquaporin-4 is a water channel, and it facilitates transport of water, and it's present elsewhere, but typically present in the spinal cord, optic nerve, brainstem. And what we are now measuring is an anti-Aquaporin-4 antibody. And as it happens, this is fairly specific and fairly sensitive for neuromyelitis optica spectrum disorder. So this is the new name. The Americans have got on it. They've taken away devic, and they put in neuromyelitis optica spectrum disorder. And these are the characteristics of this. They get an optic neuritis, they get longitudinal transverse myelitis, they get inflammation in the midbrain, and they're Aquaporin-4 antibody positive. And so there's certain diagnostic criteria now that we have for this. So what happens in this condition is that your Aquaporin-4 water channel will be attached to maybe the astrocyte. There'll be a blood-brain barrier, and you'll have your circulating Aquaporin-4 antibody, and it makes its way across. And then you get a very aggressive inflammatory reaction. And the poor old astrocyte and the oligodendrocytes, they struggle, and they don't like this, and they die off. And then you get a very aggressive macrophage incursion, and scarring. So the process starts off with facilitation of the antibody through the blood-brain barrier, and then you get a lot of destruction, and then you get scarring. And the process is a gradual process, but once you get down to F, the prognosis for visual and spinal recovery is very, very poor. So it's a very aggressive inflammatory process facilitated by an antibody against a water channel. And what can you do about it? Well, you can suppress the immune system. You can just give general immunosuppression. And we tend to give high-dose steroids. You could give azathioprine, or you could give mycophenolate. So we generally give immunosuppression. Now, nowadays, I would probably not give azathioprine or mycophenolate. I'd probably go for high-dose steroids and then the next step. The next step would be removing the antibody with plasma exchange, and that's very effective, but it's a temporary issue. And then modulating the antibodies with an anti-CD20 monoclonal antibody, rituximab, and use of rituximab has a tremendous effect on this, and most patients, 90-odd% will not have a further attack. And if you can initiate early and aggressive treatment, they'll have a very good prognosis. There are now other monoclonal antibodies being developed, attacking the Aquaporin-4 IgG. Now, rituximab is about 1,500. In the US, these other new monoclonal antibodies are planning to be about 250,000. And they've been compared to azathioprine, but not to rituximab. So in our patients, almost all will now be on rituximab every 6 months, and some are on steroid, but some not. But it's kind of a clever way of treating them. This is what happens in atypical optic neuritis. So a typical optic neuritis in the context of MS, generally aged between 20 and 50. It's generally unilateral, painful. Pain lasts about 2 weeks. There's no inflammation when you look into the eye. And the outcome for visual recovery is very good. So that's a typical one that we see in MS, and we probably do nothing. I do these tests. So I do full blood count, glucose, cholesterols, plasma viscosity, serum protein electrophoresis, infections, autoantibodies, and I test Aquaporin-4 and also a MOG on patients. MOG is more of an experimental one. Serum ACE for sarcoid, and I tend to do an MRI of brain, cervical spine, may do a CSF. So this is what I would give to every patient now. An atypical optic neuropathy, as we've seen earlier on, younger or older. So if they're younger than 20, over 50, that's unusual. If it's bilateral, that's unusual. If it's very rapid or very gradual, that's unusual. They don't get better. Pain for a long, long time. And if there's inflammation when we look in. And when it's atypical, you need to do further tests, you need to protect the eyes, and you need to consider systemic treatment. So it's a pity I don't have the wherewithal to do not questionnaire, ask you guys what is happening here. But this is a DI. So since lockdown, I haven't used a direct ophthalmoscope, and I suspect no patient coming into AMU will have had direct ophthalmoscopy. So no patients coming into 23A have direct ophthalmoscopy. But you can look into the eye. You can attach this to your iPhone, and you get this picture here. So I'm only seeing half of that, I think, but I'm not sure. Can the rest of you see this? So if I could, I would have asked you all, what would you document after seeing a fundus which looks like that? And I am certain every one of you will say that that was normal, and you'd be right. So this is normal. So if you had somebody who had visual loss and they had an inferior hemisphere problem, acute visual loss, this looks like an anterior ischemic optic neuropathy. And this would be a partial infarction of the circle of Zinn-Haller. So the little blood vessels going around, and it can be arteritic or non-arteritic. If you looked in and they had this one, you'd say there was papilledema. So there's no papilledema, papilledema, and this is a papillitis. So this is inflammation in the optic nerve head. So this is what we need to use now. Now, the other thing which is very important in all this is the tempo of visual loss. So how rapidly does it develop? Does it develop in seconds or in the first 24 hours? Does it develop subacutely over days? And does it develop chronically? So to get an idea of tempo, I asked my friend Darren whether I could use a video of his swing. So this was taken before lockdown. So Darren is a professional golfer, and he is an Open champion, an ex-captain of the Ryder Cup. So that's Darren Clark. He said, under no circumstances will I to use his swing to demonstrate tempo. It's not reliable enough. Use Rory instead. So decided to, I can get this out. So this is tempo, the rate of change. Rory McIlroy, world number 1. I saw him when he was 14 at the West of Ireland. And his backswing is 3 times the duration of his downswing. And every club is the same. Oh.
Sorry, Jonathan, we can't see your exciting video.
Hold on.
You perhaps need to share a different part of your screen.
Can you see it now?
Nope. If you unshare your screen and then share again the bit that you meant, the video, then we should be all right.
You see it now?
Not quite yet. It sounds very impressive, but we can't see it, I'm afraid.
See me.
I can hear you, I can see you, but I can't see your videos. There you go, we see it now. On you go.
Most disappointing.
There we go.
Anyway, there's Rory. Worth watching. So he's downswing and backswing. He's very consistent, world number 1, and everything is the same. So if he swings with the driver, swings with an iron, swings with a wedge, it's the same. And this is what happens. So this is reliability, this is excellence, this is consistency. Not so good with the chips. Actually, I hope John Davidson is watching, because this is what he's aiming for, this sort of consistency. If you don't have this, then it's a problem. He's pitching, I don't think this is good. So it's all about reliability, consistency, application for excellence. And it's smooth. And that's tempo. And this is more tempo. Oh, get out of there. So I need to go back. Am I going back, Tom?
We can see you at the moment. We just need you to share your presentation back again.
I go back here. So that's tempo. And in the context of an optic neuritis, a very rapid tempo probably means ischemia. It's atypical for an MS-related one. Subacute, typical, and very chronic is different. In your history, you need to find out whether patients have had recent infections or vaccinations, constitutional symptoms, ulceration, asthma, family history. So in our case, number 1, he was a little bit atypical. It was bilateral, kind of got worse over time, poor recovery. So he had a lot of these, and that should have set alarm bells ringing. So why don't we treat these patients more aggressively? Or why is it that our policy is to observe, it'll get better, It's a typical thing that happens in MS. It's mild, and giving you something will have no difference in your, make no difference to your visual outcome. So the elephant in the room is a thing called the Beck study. And the Beck study was done a long, long time ago, and it has been part of the neuro-ophthalmology dogma since. So this is it, published in 1992, looking at a trial using corticosteroids in the treatment of an acute optic neuritis. And the result was that there was it speeded up visual recovery, but the eventual visual recovery at 6 months was no different. Maybe slight difference in color contrast, but visual acuity was no different. So this has remained. And the perception is that by giving steroids to patients, it makes no difference to their visual outcome. And the other thing that this study showed was that if you gave oral steroids, they developed MS earlier. So there are two odd things about this particular study, and this has become ingrained in the management of these patients ever since. And because of this, the management is generally don't give steroids because it'll make no difference. What hidden away in the article was that if visual acuity was worse than 20/40, so that's 6/12, you give them high-dose steroids followed by oral steroids. And this is lost. So we generally, or the general treatment is ever so slightly different than what we should give. These are another case. So this is a 51-year-old female, acute visual loss over 12 hours, which was painless. And vision went from 6/6 to 6/60 over 12 hours. So in your mind, you're thinking there are lots of atypical things going on here. It was acute, less than 12 hours, painless. So these are two quite significant things. And when we used our DI and looked into the retina, there was this. And this is a very, very pale retina. That's typical of a central retinal artery occlusion. So an ischemic event. But the alarming things were these two here. So a different one, so 76-year-old male, progressive visual loss for years and years and years. And vision is getting slowly worse from 6/60, 6/24. Again, not typical of an optic neuritis, is it? Unilateral visual loss, it's painless, pale disc, and this guy had a tumor compressing the optic nerve. So, but the atypical features were these two. This is another one. So acute visual loss over 24 hours, again, painless. 36-year-old female. So female, 36, maybe optic neuritis, but it's painless. So that's a bit unusual. Acute visual loss over 24 hours, but too quick. And vision went from 6/6 to 6/24. And the fundi looked like that. So that's the opposite to the first one I showed there. First one looked very pale. This looks very congested. So this would be in keeping, and I'm sure you're all agree, central retinal vein occlusion. So it's a congested retina. So an atypical optic neuropathy tends to be younger, older, bilateral, acute or chronic, poor recovery, painless or prolonged pain, and there may be inflammation posterior anterior chamber. So these are a second tier of investigations that we can do. Infections, typically toxoplasma, that can cause a papillitis, a mitochondrial disorder, malignancy, Inflammatory is in sarcoidosis, or deficiency. So these are, we don't generally do these, but we do them if we're not sure. So when you're dealing with an optic neuritis or an optic neuropathy, history is very important. The tempo of visual loss is very important. The association of pain or no pain. What you see may be sparse, and you will investigate. You'll do your systems review, family history, may not consider steroids. I think they need to be seen fairly soon after the visual loss, because if it gets worse and worse and worse, then it may be something different to a demyelinating optic neuritis as in MS, maybe something which you could have intervened, but if you didn't, well then, okay. So this is my final slide. It's another golf one. This is actually Kings Barnes. It's the 15th in Kings Barnes, and it'd be nice to have a paddle board on the North Sea here, but it'd be nicer to just to play here, to be there. Thank you very much. That's me done.
Right, thanks very much, Jonathan. That's in equal parts petrifying and fascinating. So, any ophthalmologists in the audience? It strikes me that this is a ophthalmological thing. I'm just looking at the participants, perhaps. Hang on. Stuart Gillen is here. Stuart, have you got any comments about visual loss? And I mean, it strikes me that the differential is pretty wide for moderately rapid onset of visual loss. You know, retinal detachments, vein occlusions, arterial things. Have you got any comments?
Nothing really to add. I think you know, the key things are, you know, exactly as Jonathan was saying. And thank you very much. That was really good. Really enjoyed it, Jonathan. You know, the rate of visual loss, the depth of visual loss. Always checking pupils to look for an RAPD is always a good sign as well to look for. So nothing else really to add. I was actually going to ask a question, because it was interesting you were talking about the Beck study, and that has been, you know, it still pervades our management structures as well. I think we're always taught that for exams about the downsides of steroids. So it was really good to hear that you've got, you know, good evidence that it's a positive step, not something to be avoided. Is there any situations that you'd be more worried about using steroids? For example, thinking about the infectious causes and that sort of thing?
I'm not. You know, I tend to be less worried and less concerned. I think even with toxoplasma, I'd be using some steroids. I think the Beck study is interesting because if you look at the abstract, you'll be, I think, led astray, and the outcome is good for most patients, but for some patients who have bad vision during the optic neuritis, the outcome can be terrible. If you think it's an inflammatory process, I think they need steroids if their vision is significantly compromised. You'll often have a papillitis, but they'll still need steroids. So I'm not, even with Our Lady with TB, she got very, very high dose steroids and anti-TB treatments, but
And can I ask another question as well? It's interesting to hear you're enjoying the DI attachment for your iPhones. Have you found it to be equivalent or better than the direct ophthalmoscope?
You know, the direct ophthalmoscope, we've stopped. Our ability to use it is very poor. We can't use it now anyway at the moment. So I think anything is better. But I think with our direct, we just look at the fundi. We just look at the disc, and we forget everything else. And you don't have any. You're not supposed to have a record anyway with the DI, but you do have a picture. So it's. I think things are better. But we do need something, because most places have nothing. I'm
interested in this little iPhone add-on device thing. is this something that's very easily available? Is this something that we've bought loads of so we can use them?
Don't think we bought any. There's a company that make them, and there'll be a number of different attachments. And I think going forward, we probably won't be using direct ophthalmoscopes anymore.
Yeah, and it's something which I think you need to practice. You need to keep in practice, and we get good for our membership, and then after that it perhaps just fades away a little bit. I do agree with you that, you know, when we do it, we're looking at discs, we're looking for a papilledema, and we're probably just not good enough to look at the rest of the things.
We're probably not looking at anything.
So perhaps another good thing that might come out of COVID. Has anyone else got any questions from or comments from in the chat, or just want to speak up? I remember your TB case presenting to AMU, and Dave and I spent some time going through the respiratory part of it. I hadn't realised that that she'd gone on to develop this. You mentioned a couple of times that in your review of the cases from Queen's Park that patients often had TB. So what's the link?
About 10%, maybe less than 10% had TB.
But that's still higher than the baseline prevalence of TB.
Yeah.
In the population. Is there a link?
I don't know what the link is. It's something that seems to happen. I think in our joint case, she probably had a predisposition. So she's got an autoimmune profile. She's got lupus, and she clearly had that beforehand. She's got TB, and then she develops these Aquaporin-4 antibodies. Now, she probably didn't have them before the development of her TB, but I'm not aware of any definitive evidence or immune mimicry regarding the tuberculous, mycobacterium itself, and Aquaporin-4, but there's probably something in the mycobacterium which is similar to the Aquaporin-4 water channel. Certainly, it's more common than you might think.
Yeah,
very rare, but
very interesting. Okay, well, if no one else has any questions or comments, then I'd just like to thank you very much for what I thought was a fascinating talk, and a really salient point that people presenting with sudden visual loss is a medical emergency and something to be treated very seriously, and to call experts, which and not mess around. This comes to a conclusion. The academic year 19 to 20 grand rounds. We've had something of the order of about 40 different presenters over the last 12 months. And I've learned a lot. It's been fascinating. It's been very interesting moving from standing in the Ganachie Lecture Theatre to doing this in a virtual way. I hope that you still find it helpful, interesting, and useful. You can watch all of the videos on YouTube by following our YouTube channel, and I have a bit of a project to do to try to get through the backlog of the 2016 and 17 videos, but I keep going with that. If you are itching to give a talk at Grand Rounds, please email me and let me know the topic. I have slots through September, October, November, and even into December. Get in touch so we can give you an opportunity to give a talk, or if you have a trainee, or if you're a student and you want to give a talk, please let me know. So thanks very much. Thanks again, Jonathan. Fascinating talk, and goodbye.
Bye now.